Hello and welcome to everyone. I am Sarah Ramaya, Curriculum Design Specialist at ASRM. Welcome to this webinar on the new SART data tools. Please join me in welcoming my colleagues Jessica Goldstein and today's moderator, Dr. Amanda Callan. Before we begin, please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type your question in the question chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. Let me introduce our moderator, Dr. Amanda Callan, an assistant professor of obstetrics, gynecology, and reproductive science at the Yale University School of Medicine. Dr. Callan is active with ACOG, previously serving on its executive board as the National Junior Fellow Congress Advisory Council Chair. Her research focuses on the molecular mechanisms that regulate hormone production and fertility, and she is the recipient of the Reproductive Scientists Development Program grant for her work. I will now turn the presentation over to Dr. Callan to introduce today's panelists.
Thank you so much. It's my pleasure to introduce our first speaker, Dr. David McCullough. Dr. David McCullough is a research associate professor in the Department of Obstetrics and Gynecology at NYU Grossman School of Medicine. He is the assistant laboratory director at the New York University Langone Fertility Center and the lab director at Biogenetics Corporation and the Sperm and Embryo Bank of New York. He is the director of clinical science at ReproArt, the Georgian American Center for Reproductive Medicine, and consulted for the Medical Center Girona, both in the Republic of Georgia. He earned his PhD from the University of Maryland and serves on the SART Registry Committee. Prior to his clinical endeavors, he was involved in basic research, investigating sperm-egg interactions using cellular electrophysiological methods in sea urchin eggs. Dr. McCullough, I'll turn it over to you.
Thank you, Dr. Callan. The learning objectives for this portion of the presentation today are to learn where and how to enter data regarding the COVID-19 situation. We have three basic things that we can enter. First is we can deal with patients' concerns or facilities' concerns regarding COVID. We can deal with patients who actually had infections and had positive COVID testing. And we can deal with patients who had presumptive COVID infections but never had a positive test. So the fear concern that we've been going through, because we didn't have a good way to really know whether patients were positive or not for quite some time, that led to some cycles being canceled or halted. Patients called us, said, I'm not willing to come in and risk things, so they wanted to back out of and cancel cycles, or they may have opted not to have a transfer after they had already had a retrieval, or if they had already started an FET cycle, or they could be halted at any stage, due to ASRM recommended cessation of treatment, because on March 17th, I believe, there was a directive that we should consider shutting down. So that's the fear and concern side of things. And then there's the side where patients actually have complications associated with COVID-19. We want to know who had COVID testing with a positive result. We want to know who had COVID-19-like symptoms but did not have a positive test result. And this applies when they were during their treatment. For patients, it's between the cycle start and through delivery. We want to know if patients came down with symptoms or with positive testing while they were pregnant. And it also is reportable for infants from their delivery until the infant's release from neonatal care. We don't want to know if they got the virus when they were 6 months old. We only want to know if it was something that occurred basically in utero. There are 3 different tabs in SART cores where you can enter this information. The first is the ART treatment tab. Second is the transfer and outcome tab. And the third is the delivery tab. On the ART treatment tab, you can enter cancellation of cycles, and you can enter the complications, where you indicate whether or not a patient had positive test results or was symptomatic. The second tab, the transfer and outcome tab, you can put in a reason for no transfer, if they backed out of having a transfer because of concerns or because of positive test results or because of symptoms. And in the delivery tab, you can enter information about whether the infant was born with the complications, with a positive test result or with symptoms. So why do we want to know this stuff? Well, we want to know how many cycles were stopped early due to concerns about COVID-19, and we want to know if there were any adverse outcomes, miscarriages, stillbirths, neonatal deaths, also perhaps even a decrease in pregnancy rates. So we want to know if that occurs more frequently with patients who have COVID-19 symptoms or are confirmed COVID-19 infections. So we'll move on to the tabs. This is the ART treatment tab. The big arrow at the top points to that tab. The little arrow at the bottom says we need to go to the bottom, where you can enter that the cycle was canceled. There's a check box for canceled. When you check that checkbox, the encircled in red, cancellation COVID-19 related checkbox appears. It doesn't appear until that canceled box is checked. Same with the cancel reasons. So you can select a cancel reason from the drop-down list over at the right, and you can also select cancellation COVID-19 related. If the cycle was canceled because of concerns or positive testing or symptoms, you can check that box saying it's canceled because of COVID-19 related things. The next item in here is the complications. Over at the far right, there's another circle, and we have two check boxes available. One is COVID-19 positive test. So if the patient had a positive test, and this happened during the cycle, you can check that checkbox for COVID-19 positive test. If the patient did not have a positive test, but had a presumptive COVID case where there were symptoms, but there wasn't any testing performed, then you can check that second checkbox to indicate that there was a complication in this cycle that led to something. Maybe the cycle went through just fine, but if there was this complication during the cycle, we want to know about it, even if the patient delivered and everything was fine. The second tab, the transfer and outcome tab, where if there was no attempt to make a transfer, so that transfer attempted box above the circle is not checked, then you have to provide a reason why there was no transfer. And the no transfer COVID-19 related that's encircled in red, that checkbox will be there as long as that transfer attempted box is not checked. If the transfer was not attempted because of some COVID-19 reason, either concern or positive test or symptomology, then you can check that no transfer COVID-19 related checkbox. The final and third tab that we work with, the delivery tab, and in this one, when you report the birth of a baby, you have the option to indicate under birth defects. We don't generally do, this is not a birth defect clearly, but we have it there because it's the best place to put it. We want to know whether the child was born with COVID positive, well, was tested, if the baby tested positive right after delivery, or if the baby had symptoms that made us believe that the baby had COVID-19. We want to have those things indicated for each child that's born. So that deals with the places where we can enter information about COVID-19 concerns, testing, and symptomology. Thank you.
Our next speaker, Dr. Brad Hurst, is the Reproductive Endocrinology and Infertility Division Director and the Director of the ART program at Carolinas Medical Center in Charlotte. He is a current member of the SART Registry Committee, a past president of SREI, and has served as the SREI representative to the SART Executive Committee from 2017 to 2019. Dr. Hurst?
Okay, well, thank you. So I want to first say that I have nothing to disclose, and then secondly, introduce everybody to the new normal. I think we're all dealing with the new COVID world. We certainly are in our program, still dealing with kind of the world as it is. Cartoon says it's funny how day by day nothing changes, but when you look back, everything is different. That's certainly true of the world now with COVID, and at some point this really will be the new reality. And it certainly has been true in the past through all of the evolution of assisted reproduction. So I am old enough not to remember when the registry began as a voluntary program in 1985, but was certainly in practice in the early days when reporting was federally mandated as part of federal legislation, so that all ART programs had to report outcomes to the CDC. SART was a leader in this, and from the very beginning has worked with the CDC to ensure that reporting is accurate, and also to be sure that that it's not overly intrusive to practices. In the very beginning, I thought this was the worst thing ever, and I think most practitioners at the time felt like this was a big imposition. But I think this is something that we have just learned to cope with. And since then, assisted reproduction has changed markedly. There's two things that I have to talk about. Both of them, I think, are really good news. The first is new changes in reporting for embryo and oocyte thaw cycles. And the second will be linkage for oocyte donation cycles. So let's start with just reporting in general. I think we all recognize that prospective reporting is really essential for accurate reports and also to have believable reports. After all, if you wait until completion of the cycle or completion of the month or completion of the year, it's really quite easy to forget cycles that were failures. When we do frozen embryo transfers or oocyte thaws, if we do a warming or a thaw and embryo doesn't survive, we don't have a pregnancy test to remind us that the cycle was a failure. Likewise, so it's possible without prospective entry that the reports are better than they really are. And the other thing is that once a patient has a viability ultrasound or delivers a baby, if we haven't entered the data at that point, it's an easy reminder to go in and make sure that we enter the data. So those are things that can be just omissions that make programs look more favorable than perhaps they should be. And on some circumstances, sadly, programs have been accused of gaming the system so they look better. Prospective reporting prevents that from occurring. So in the past, a cycle start was a cycle start. And that was true with ovarian stimulations for egg retrieval procedures, but it was also considered to be true with the cycle start for frozen transfer cycle. What you can see is our report card. This was, I think, the year that I started on a registry committee, so we had to do a really good job of making sure that we had prospective reporting. But it's listed for cycle starts for stimulations on the CSR report. For frozen transfers, it's also recorded, but I can tell you that for our program a few years ago, we had an astronomically high cancellation rate for frozen transfers from patients who had poor endometrial development or patients who had medication error or bleeding or spotting before transfers. And none of those really, for cancellations, would be a reflection of the quality of the embryos or quality of the thawed eggs, or really the cryo program success outcomes. The only thing that would matter would really be failed thaw or warming of the cycles, but that was entered with a group of other things. So really the good news and the bottom line for the first part, thaw cycles, is that the reporting requirements have changed, and now the requirement is to enter thawed oocyte or embryo frozen transfer cycles at least 1 day before the thaw and warming date. This still provides prospective reporting, but it really minimizes the irrelevant cancellation rate for things like poor endometrial development or patients who change their mind or have spotting. Just like the old rule, if any of the key fields are changed, that causes the cycle entry to reset, the date to be reset. And so it's important to know that key fields have to be set before the deadline for prospective reporting to count successfully. So that's my first bit of good news, but there's more. The next bit of good news is the linkage of oocyte donation cycles. Again, going back to the beginning of early days of ART, it has always been the responsibility of an ART program to enter data about the donor, whether the donor was direct or anonymous donor. But that information was all available because the donor was a donor in our program. So we had the information about date of birth and all of the important fields that needed to be entered. Today, if you use eggs from a bank, entering the oocyte donor information from banks can be extremely painful. So in the past, as of a few weeks ago, when programs entered information from oocyte donations, especially from banks, some of the banks are really good and they give a lot of information about the donors and provide all of the information about the donors. But some of the banks provide incomplete information, and it makes it difficult or impossible to fill out the fields that are required by the SART entry program. Also, when a bank goes through a stimulation cycle, they hope to get donors who have lots of oocytes. When they have lots of oocytes, the donor is split into a number of cohorts. Those cohorts can be sent to a number of different clinics. And then the donor oocyte information has to be completed by each clinic for each thaw. And there's so much redundancy that it ends up being a lot of wasted time involved in the process. Some of the information can be incomplete, and sometimes the cycle is closed without all the information. Or if the information is incorrect, it makes the data useless and time-consuming. So we want to encourage instead of complain. The solution to the problem moving forward is ideally to have egg banks enter the donor data into SART cores. And that way data can be linked from the donor cycle to ART procedures, and providing a lot of time reduction, time saving, and improved accuracy of the reporting. Of course, SART and especially the registry committee have nothing that we can force the banks to enter this data. So each of the programs should encourage the banks directly to enter the data so it can be linked and make everybody's lives easier. So those are my two good news items, the ability to link cycles for oocyte donation and reporting frozen transfer, entering data for frozen transfer cycles the day beforehand. So it's important for everyone to know that the SART and the registry committee, we're really all working together to try to make things as accurate as possible. The technology changes, and as technology changes, we need to do the best we can to stay on top of the changing technology. And anytime we can, our goal is to reduce the burden of reporting while committing to accurate reporting. Smart Guy one time said, make everything as simple as possible, but not simpler. And I think that's the overall goal. So again, thank you very much.
Great. Thank you so much, Dr. Hurst. We have Dr. McCullough, who's going to speak again now. The topic of these next few slides will be new fields for PGTA, specifying PGTA results for transferred embryos.
Well, hello again. What we want to do is learn where in SART cores and how to enter the PGTA results for transferred embryos. There's a couple of steps. The first one is the step that's required in order to make the fields appear. So what has to be entered to make the PGTA field available for entry? And then the second thing is how to enter the PGTA results. For embryos with no result, could have been biopsied but had no result. With euploid or normal embryos, with aneuploid embryos, ones that have whole chromosome aneuploidy or only segmental aneuploidy, and how to enter the information for mosaic embryos. These are embryos that have either whole chromosome mosaicism or segmental mosaicism, but do not have any full-blown aneuploid chromosomes or segmentals. So why? Why do we want to do this? Well, we would like to compare success for embryos with results indicating euploidy, aneuploidy. These are ones that only have segmental aneuploidy. It means a partial aneuploidy or a deletion or duplication. Or they have any aneuploidy involving at least one whole chromosome. These aneuploid embryos may also have mosaicism, but if there is anything that is not mosaic, it's considered aneuploid. And then finally, we want to be able to look at how things go when there is only mosaicism, when there is only segmental mosaicism or only whole chromosome mosaicism, but there's no non-mosaic aneuploidy reported. Well, data entry involves two different tabs, again. The first tab is the donor and retrieval tab. The second tab is the transfer and outcome tab. In the donor and retrieval tab, you're going to specify that PGTA was used for at least one of the transferred embryos, and you'll specify a reason for PGTA use. The reason for PGTA use only becomes available when you indicate that you have done PGTA on some or all of the embryos. And then the reason that you pick for PGTA, it must be one that is that results in the appearance of the PGTA reporting tab on the transfer and outcome. Will make the PGTA drop-down result field appear on the transfer and outcome tab. That's where you will indicate the results of PGTA. So here is the donor and retrieval tab, and you can see a black bracket there down low in the micromanipulation and fertilization area. And the first thing you have to do is for that pre-implantation genetic testing drop-down list, you have to either specify some embryos or all embryos. If you're transferring one embryo and it had PGTA, then your answer would be all embryos. It's for the embryos in the transfer, in this case. If you're doing more than one embryo and not all of them had PGTA, you could put some embryos. And then the second place that you need to specify something is in the PGTA indication. You can check all that apply, but you actually have to specify one that indicates that aneuploidy determination was done. And we'll go through that more in a second. All right, so now we're looking at something on the transfer tab. And in the upper little box, you can see that there is the description of the embryo. There's, it was an elective single embryo transfer, yes or no. What was the grade? It was good. It was an expanded blast. It was good intercell mass and good trophectoderm. But you're going to have to show that there was some pre-implantation genetic testing done on that previous slide, and you have to select the right PGTA reason that includes aneuploidy in order to have this encircled PGTA field appear in the lower box. That's the field where you're going to specify whether the embryo was normal, aneuploid, or mosaic, or no result. Okay. So in order to make that field appear, you have to do the things that I showed you on the previous slide. We'll go on to the next slide, and I think we'll get more detail about it. Okay, so here's that micromanipulation and fertilization area again on the Retrieval tab. And the first thing you have to do is select something in the pre-implantation genetic testing field. You can enter either some embryos or all embryos. And right now, if you try to enter it, you're going to need to have one of the aneuploidy fields checked for PGT indication. The ones that are shown here and are encircled all have aneuploidy in the name. Clearly, they're dealing with aneuploidy. We are in the process of updating these so that that box will appear for just about everything except for HLA stuff and single gene testing, if those are the only ones that you have entered. If you do single gene analysis and aneuploidy, you should check one of the boxes that deals with aneuploidy. Same with the HLA. So indicating a reason, a PGTA indication is important. That's what dictates whether that field will appear or not in the transfer tab. So we go on to the next field, it's the transfer tab, and you can see down there at the bottom the PGTA field has appeared because we checked the appropriate boxes in the Retrieval tab. And here we have 4 different options. Once that field has appeared, you're going to have to fill it in. You can either select normal, that's the top one. The second one is aneuploid. The third one is mosaic. The fourth one is no result. Now, if the embryo is euploid, it's pretty straightforward. I think most of us, when we transfer PGTA embryos, are transferring ones that are normal. So most all of them, I imagine, that you transfer will be indicated as normal. If you happen to transfer an embryo that does indeed have a result that is aneuploid, meaning there is at least one aneuploid chromosome that is not mosaic, or at least one segmental, or partial aneuploidy that is not mosaic, then you will select aneuploid in this box. If you have an embryo that has nothing but mosaic chromosomes or segmentals, then you can select mosaic. And if the embryo was tested but there was no result, you can select no result. Also, if you happen to have 2 embryos transferred, one had PGTA and one did not have any PG testing, then you would, for the one that doesn't have any testing, you would enter no result. The one that does have testing, you put in the appropriate results for that. So now, there are the 2 cases where you might select aneuploid or mosaic, and we have to go into more detail with those, and we'll go into that detail in the next 2 slides. This is if aneuploid is selected, then a new drop-down list will appear, a new set of fields, and you will have to select either whole chromosome aneuploid or segmental aneuploid. If there is at least one whole chromosome aneuploidy in the embryo, you select whole chromosome aneuploid. That's what determines whether it's aneuploid. It can have mosaicism elsewhere, but if there's one chromosome or one segmental that is not mosaic, then you have to select one of these. If the worst offender is a segmental aneuploidy, then that's the one you'll pick. So if it's a partial aneuploidy or a del dupe, you would select segmental aneuploid. If there is a whole chromosome aneuploid, you will select that. Now the other option is if you're selecting rather than aneuploid, if you're dealing with a mosaic embryo where there are nothing but mosaic calls, then you will have to select that there is a whole chromosome mosaic, if there is a whole chromosome mosaic. If there's nothing but mosaic segmentals, then you will select mosaic segmental. This drop-down list will appear when you select mosaic in the PGTA field. So note that when a mosaic is chosen, there must not be any non-mosaic aneuploidies in the test result. And that is pretty much the description of how we're going to enter these. These are all live now in SART cores, so you can use them today. Thank you.
Thank you so much, Dr. McCullough. Our last speaker today is Dr. Amy Sparks. Dr. Amy Sparks is the ART Laboratory Director at the University of Iowa. She has served on the Registry Committee and is currently the SART past president. Dr. Sparks is going to be speaking to us today about the SART Mobile App.
Thank you so much, Amanda. I have nothing to disclose. Okay, so the SART mobile app was actually introduced almost 2 years ago. Redshift was able to develop this app for us with a grant from Ferring Pharmaceuticals. And so I want to review some of the highlights and remind you of the tools that you could use to improve efficiencies. I think as our clinics are starting to ramp back up and patients are very excited to start treatment again, we know that our workload is going to be great, and we'd really like to make things as efficient as possible when we're communicating with patients and collecting outcomes for cycles. The app is available for both Apple and Android products. This is what it looks like. The main menu has a Find a Clinic feature, very much like what you see on the SART.org website. Predict My Success links to our patient predictor. The pregnancy wheel is Ferring's pregnancy wheel, so the patient can get estimates as to the due date and where things are rolling. Programs that don't have an option within their own EMR or would prefer another option can utilize secure chat. And there's even an appointment feature on this app. The other piece that I'm going to focus on today is that you can actually get some assistance from the patient to confirm cycle start as well as cycle outcomes. So there's a really nice document on the SART Core's website under the Home tab. I encourage all of you to look at that PDF because it gives you very clear instructions along with screenshots to guide you through how to launch the mobile app in your clinic if you haven't already done so. There are two features that you do have to trigger in order to get the app going in your program. One, under clinic info, you'd have to check allow the mobile app. Now, when I first looked at the screen, I'll be honest with you, it was a little intimidating because I thought, oh no, I don't want another feature for chatting with patients. We do plenty of MyChart through Epic here at our institution. But you may say, well, either we don't have something available in our clinic, or in our situation, I think our patients actually get a little fatigued from all of their MyChart messages. So having a unique channel for communication may be beneficial. Additionally, you can decide whether or not you wish to use the appointment scheduling feature, and then you can regulate how often members of your team are alerted to email to appointment requests, chat requests, if you've triggered both of those options, and as well as patient cycle start confirmation and patient pregnancy outcome confirmation. The other piece that you have to activate to get this started is that the users in SART cores also have to have the mobile app checked under their access. That's a really important part, because what you'll eventually do is go into the patient table and add an email address. If the user using SART cores doesn't see the email field in the patient table, it's because the mobile app feature hasn't been activated within their user area. So it's both the clinic and the users, the staff of the clinic, have to have the mobile app activated. So if we do have this option, you've activated it both for your clinic as well as the user in SART cores, you can invite your patient by putting their email address in and invite them to download the app. If you start a cycle, you can ask them to confirm that they've started their cycle, and they'll also see their date of birth. You know, a lot of us are hand entering all of this, and sometimes we make some errors, so it's kind of nice to have the patient confirm their date of birth rather than you catching it later on. And then they can tell you whether that information is correct or not. So if the patient gets invested, you're invested. If your clinic happens to have some communication challenges, getting all of this to the data entry people in a timely manner, especially for prospective reporting of the fresh cycles, this is just a nice way to reconfirm things. So again, the cycle start, you enter the cycle start, you're prospectively reporting, whether you're doing it for the fresh cycle or the day before the thaw, as late as the day before the thaw for an egg thaw or an embryo thaw. It'll send a push notice out to your patient saying, oh, well, a cycle has been started under your registration. So a patient can either confirm or deny it and say, no, I'm not starting this cycle, or I've changed my mind, or something's come up. So you can then, if they confirm it, though, you'll see it on their screen within SART cores, as you can see to the left here, next to the start date, that the patient has indeed confirmed her start using the mobile app. Report outcome, I think this is actually, to me, one of the biggest benefits of the mobile app. We all joke about how people are doing binge SART course entry and clamoring to get the last cycle outcomes before the reporting deadline each year. This is a beautiful feature, and I really encourage all of you to explore this. If this is the only thing you use the app for, I think you're going to love it. I really do. There's no need to call, because as long as the data in SART cores is up to date and you've indicated that the patient has had either a heterotopic pregnancy or a clinical intrauterine gestation, and there's been no report of that pregnancy concluding either an abortion or a spontaneous loss, a termination, or other poor outcome, it stays open, and the patient can then fill in their outcome information anytime they wish. If the pregnancy is ongoing, 10 months after the start date, a prompt will be sent to the patient asking them to complete their outcome information. And this is what it looks like. They'll populate what the outcome was, the date, method of delivery, number of offspring, number life born. You get the picture. So, and then the clinic is notified as soon as the patient, based on your preference as far as the frequency of notification, the clinic can be notified that the patient's completed this, and then you can reach out, congratulate them, send your condolences if the outcome was not favorable. I think this is something people have to seriously start considering, because it does take a lot of time to reach out to our patients. And I hear programs complaining about patients that are overseas. It's more difficult to reach out to them. People have this app downloaded. They can actually help you with very secure reporting using the outcome feature on the app. So again, we thank Fairing for supporting this effort. I do encourage you to look at the whole PDF that's under the Home tab of SART cores, and SART support's available to help anytime you're ready to get started. Thank you so much.
Thank you, Dr. Sparks. We will now open the floor for questions. Dr. Callan will be moderating the session.
Okay, thank you so much to all of our presenters today. We have a lot of great questions, so I will jump right in here. I think I can address our first question to Dr. Hurst, but obviously anyone can jump in and answer as well. And we have a couple of questions kind of addressing the same concern. So Dr. Hurst, for SETs to be prospectively reported, it seems like the thaw date and other required information needs to be entered the day before the thaw, and the program doesn't allow it to be entered 2 or more days. And then a second question, can we get a longer window for entering the thaw date prospectively? Right now it only appears to be enterable to the day before. So could you clarify that data entry window?
Yeah, it can be entered before then? Amy, you're shaking your head.
Yes, it can be entered well in advance. It's just, I think a lot of programs would complain that they weren't notified when the patient had started estrace or for natural cycles. It was really difficult to prospectively report within 4 days of that start. So by allowing it to be as late as the day before the thaw, it just makes us so much more convenient, I think a little less stressful, to prospectively report the cycles.
I think the simple answer is you can continue to enter them the way we used to. You just don't need to enter them until later.
Okay, great. Thank you all for that clarification. I have a question for you, Dr. McCullough, regarding oocyte banks. And again, a couple of sort of linked questions here. How would we link our patient cycle to the data that the oocyte bank has entered, and which info regarding the donor do we need to enter that will link the donor to her information provided from the bank?
I think it's really a question for Dr. Hurst, but I'm not sure we have the mechanism worked out yet. It's that we are impressing upon the banks that we want them to enter the data so that it will be available for us to pull. Is that correct, Dr. Hurst?
Yeah, that's absolutely correct, and I'm happy for you to get my questions. Yeah, that's exactly it. Unless the bank enters the data and provides the link, it's not going to be helpful to the programs. But as consumers from the banks, the ART programs can ask the banks to enter the data so that the cycles can be linked, so that it imports that into the into SART cores. Amy?
I'm getting a little intel from Redshift. Ethan's been very helpful. So to clarify, the programs that are doing egg retrievals for banks will be the ones who actually have to enter the cycles. That's the first thing. Let's step back a minute, though. A couple of years ago, we could never enter the donor as a patient, so there was no way to put that donor in the patient table. You know, we have the patient table and the cycle table. So now you can enter the donors in that table. You create a cycle for that donor. So if I'm getting eggs for egg bank ABC, I could enter that information, and then I'll be given an ID code. That's how the banks are going to relay the information to the programs that receive the eggs. And all they're going to have to do is put in that ID code, and Redshift will take care of the linkage in the background, is my understanding. But now, let's say you're doing donor eggs within your own program. You're doing your own egg bank, you're banking eggs for your patients. Wouldn't it be nice to be able to just say, yes, we use this donor, and we're going to plug this information in, and you're not having to repopulate the FSH fields and other things. So it's not just for eggs that are being shipped out of your clinic, but it's also internally. We're just trying to make this easier so we can link the cycles. But there will be a code, and we'll make that more clear moving forward, but we need people to start entering it. And it's the centers who are doing the egg retrievals that actually need to enter the cycles for the banks.
Okay, thank you. And if anyone else has, from the audience, questions or needs clarification, just type in and I can boot those questions back out. I have a question about the mobile app. So the question is, if the patient deletes the app during her pregnancy, she's still prompted to provide delivery information. And sort of corollary question, if can you delete the patient delivery information prompt, for example, if the patient had a miscarriage or a preterm delivery?
So if the app is not on the phone, there's no way for us to push the notification out. So it does depend on but you could use their email, obviously, but you can't use the app if they've taken the app off their phone. If you have completed the cycle with a miscarriage or other poor outcome, there will be no notification sent. It's only if those fields are incomplete after 10 months after the cycle starts that the notification would go out.
Okay, thank you. We have another question, actually several questions coming in about cycles that were closed already for 2019. So I'll summarize those. If a cycle was closed already for 2019 data, will we have to reopen and add those new fields, for example, for mosaics? And another question asks, we've completed our data entry. Is the PGT data entry required for 2019 cycles, or will it be mandatory for 2020?
My understanding is it's mandatory for 2020, and it is not mandatory for 19. Is that right, Amy?
It's soft. It's available. It's the kinder, gentler SART way. So it's available for 2020.
Okay.
Not mandatory. But
not mandatory.
I think this is a big question that a lot of people are asking. How many programs are transferring mosaic embryos, and what are the outcomes of these transfers? And we have to do this collectively at this point, and this tool will allow us to do so.
Okay.
I stand corrected. It is available. It is not required.
Kinder, gentler.
Yes.
We have a question coming in about COVID and the reporting for COVID. Is it automatically considered a complication if the patient has COVID?
If the patient has COVID during the cycle, then you should report it as a complication.
There is a question about mandating donor egg banks to report. Eventually, will the egg banks be mandated to enter donor data?
Well, again, as Amy clarified, it would be through the program that does the retrievals. But I think it's hard to predict the future in this. I think all of the recipient programs and all the programs that use banks would appreciate that. My expectation is that it probably will be required at some point, but this is new. It's something that's being rolled out, but I think it has enough advantages that it will be taken advantage of quickly, and even if it's not required, I think it will be pretty universal within a year or two, if I had to predict.
The present definition of ART, dictated in the Federal Register, dictates that retrieval of eggs, taking eggs out of the body, is assisted reproduction. And it dictates that all assisted reproduction is to be reported to the CDC. So the banks are required to report, and the kinder, gentler way is to report through SART. SART will then report to the CDC, and it will make it easier for SART programs to gain the information that we want, that we're required to report in our cycles. So my understanding is it is in fact required by law. It has not really been enforced heavily at this point. We would like to encourage them to comply.
It's required of the centers that are doing the egg retrievals, though, because the egg banks are businesses, so they're the brokers of the eggs, so to speak.
Yeah.
So it's the center where the egg retrieval occurs. That would be the center entering the cycle. But I think that this is going to be enough of an advantage that the banks will encourage their centers to do so. I don't know of any bank that really loves filling out all that information for every single cohort that's going out to the recipient centers.
I'll move on to a next sort of set of questions theme here. There's questions about options for reporting NA for PGT mosaics, but you can report NA for PGT aneuploid. What if we're missing the necessary details to fill in this field? And then sort of a couple of related questions. Do we include the mosaic and aneuploid embryos in the number of embryos cryoed for IVF cycles if there's a chance the patient will transfer the mosaic or aneuploid embryo?
All right. If you cryopreserve them, you report them as cryopreserved. I think the question is whether they're considered suitable for transfer. I think that's where the question lies. And I think if you're considering transferring mosaics, and it's not research, they should be reported as suitable.
I think it's there's a lot of wiggle room there. There are some clinics that don't have mosaics reported. So it's all over the board.
Okay, and another question, how should elective PGT be handled, and will elective PGT count under the aneuploid screening? The data entry here.
That is the plan, to include it. I think that one concern that we have is that you could foresee that there would be elective PGT that might not be aneuploidy determination. So I think we'll probably opt to make elective PGT open the field, and then you will, if it is not actually aneuploidy determination, you can either report no result or NA. So it's still kind of up in the air. Sorry,
okay, another question. Another question about reporting, and a couple of similar questions here. So I'll summarize. To clarify, do we need to enter in thaw cycles that are canceled prior to thaw? If a thaw cycle is canceled 2 days before transfer, do we add that cycle on SART?
I'm sorry, that is the question I had, because I was a little excited thinking, oh, we don't have to enter all of these cycles anymore. But actually, it's still a cycle. It's just the prospective rule, the prospective reporting rule for these cycles that has changed. The cycle reporting rules, it's still a cycle, you still have to put it in. It's just the prospective reporting part that has changed, my understanding.
Well, there is another change that's downstream a bit, and that is that we are now summarizing results in the SART data per thaw rather than per cycle start for FETs and oocyte thaws.
That's
so if there is no thaw, then it won't. If there is no thaw, it will not ding you in your outcome.
Another question, and this question is for Dr. Sparks regarding the mobile app again. If a patient doesn't confirm a cycle start, does that change reporting from any standpoint? Say you report a patient has started and then the patient clicks no for some reason.
No, it would really trigger you to follow up with that patient then, but it doesn't affect your reporting. You might just end up having to move the date or delete that cycle because she really didn't start.
Okay, another question returning to data entry here, and I think this is a piggyback a bit on previous questions. To clarify, if a thaw-warm cycle is entered like any other prospective entry and then the irrelevant cancellation occurs, is a deletion of the cycle allowed rather than training clinical staff to the at least 1 day before format?
I'm not sure that I understand the last part of the question.
My take on it is that you're asking whether you can just delete the cycle if there was no thaw that occurred. It's not really. I mean, if you've already got it entered to that point, you can just leave it. It's not going to hurt your results, and it gives a truer indication of how many cycles are really not making it to thaw. It might be interesting for patients to know that.
That cycle still needs to be reported. That's the rule. That's a CDC rule. That's not a SART rule.
Okay, that's the way I'm interpreting this question as well, but if the asker wants to write in and clarify, I'm happy to clarify. We have another question regarding no result embryos. Are no result embryos considered as a potential number suitable for transfer when entering this field?
I think our general interpretation is if there is no result for the embryo, it is no different than an untested embryo, and an untested embryo is considered suitable for transfer.
If a cycle is canceled due to a poor lining, it does or it does not need to be reported. So another question.
Yeah, it's reported, but it doesn't. There's no penalty cancellation.
There is a question regarding thawing frozen donor oocytes. If we thaw frozen donor oocytes to create blastocysts for future SET, does the program need to enter it into SART cores at least 1 day before egg thawing?
Yes.
Do we have to take permission from the patient to give email addresses for the app?
Yes.
Okay. With that, I will wrap up the questions. Thank you all very much for attending, and Sarah will take over from here.
Thank you, Dr. Cullen. Thank you to our panelists for sharing your recommendations and answering questions, and of course, Dr. Cullen for moderating the webinar. To the attendees, thank you for joining us. You will receive a survey by email after this session. Your feedback helps us give you the most relevant content. Your input is appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.